Thank you, Haley. I'm Alex Bashar with Behavioral Health Community Engagement here at Nationwide Children's Hospital, and it is my privilege to present to introduce our speaker today. Dr. Kristin Crichton is a child abuse pediatrician at Nationwide Children's Hospital. She is a proud graduate of the Nationwide Children's Hospital Pediatrics Residency and is an alumni of the Hilltop Clinic. She serves as the Clinic Medical Director for the Child Advocacy Center and the Child Assessment Team Clinic. She is also the Program Director for the Osteopathic Recognition Track of the Pediatrics Residency at Nationwide Children's Hospital. Dr. Crichton, we are really happy to have you here today, and I'll hand it over to you.
Hi, yeah, thank you so much. I will share. Is this sharing? Hold on, I think we try that again.
Correct.
It did? Okay.
Yes, yeah.
Is that right?
I'm not seeing anything.
Well, share screen. We practiced it and it worked.
There we go.
There it is.
All right. And it's in presenter mode?
Yes.
Okay. All right. All right. So I'm Kristin Crichton, like Alex said, one of the child abuse pediatricians here. I think I've met some of you, but not all of you. And today we're going to talk about trauma-informed care. And so just to give a little bit of context for what my team does, we live in the Child Advocacy Center. It's the white painted brick building right across the street, right across Livingston from the main hospital. We used to have green and blue awnings, so it makes us easier to find. So we're next to Ronald McDonald, and between Ronald McDonald and Fob. And we see kids here primarily for concerns of sexual abuse in the Child Advocacy Center. So we do interviews, forensic interviews with children of all ages, with concerns for sexual abuse primarily. Also exposure to violence, some physical abuse, we can see here. And then our team also serves for evaluation of physical abuse for inpatient consults. Most of those kids are admitted to trauma. And so those are more often babies, right? So younger kids where there may be a diagnostic dilemma about making a diagnosis of physical abuse. And then we have a foster care clinic. So we do primary care for children in foster care. And that is here in the CAC. And then we also have 2 offsites at Sharon Woods and at Eastland. And I staff the Eastland clinic on Fridays. So I have time out in the primary care world where I'm seeing kids in foster care. So just kind of a lens from where I'm coming from in terms of talking about trauma-informed care, because I think it's, we all have different experiences and different populations that we work with, and it's important to understand that. So today we're going to define trauma-informed care and the importance of incorporating trauma-informed care into primary care pediatrics. We want to understand the impact of trauma on children and their caregivers, and discuss strategies for implementing trauma-informed care in primary care. So when you look for memes or like fun things about trauma-informed care, shockingly, there aren't that many. This one I found though, and I really feel like it's especially appropriate, and I feel like our social work colleagues really appreciate this. So it's not, in fact, trauma-informed to give a victim of violence a piece of paper full of phone numbers. So I think, kind of in the past, when we thought about resources, we had things like the trauma equivalent of a helping hand. Like here, you can call these places and maybe they can help you. And what we want to do is give something more rich, something more robust in terms of help for our families that are facing various problems. And we know that lots of our families are facing lots of different problems, and they come in all different shapes and sizes. So how do we approach that? Where do we even start? Conveniently, the AAP came out with these 2 papers in the last year. One is a policy statement, trauma-informed care in child health systems, and it's written by, they're both written by Coffee Cake is the acronym they call themselves. It's the Council on Foster Care, Adoption, and Kinship Care. I don't know how that spells Coffee Cake, but that's what they call themselves. So it's a council within the AAP. And Dr. Duffy, the lead author on the policy statement, is actually a psychiatrist and a pediatrician who does a lot of behavioral health, who practices in Dayton. So he's local to us. And Morris Slodgy, as you all know, is the current AAP president. So these are very well-informed people giving us good guidance on how to approach PIC in our clinics. And then the clinical report, similar group of authors. And again, this is kind of more how to implement trauma-informed care in our clinics. So we're going to start with kind of understanding what we're even talking about here. Trauma is an event, series of events or circumstances experienced by a person as physically or emotionally harmful that can have long-lasting adverse effects on the person's functioning and well-being. And that's from these papers, the definition. So I think what's important to me and what I've learned in working with our population here is that I cannot know what event will be traumatic to a child. Like we can kind of imagine events that are traumatic and we have an idea of it, but there's not like a more traumatic or less traumatic. We'll have kids come in and disclose something that, in terms of like a sexual abuse kind of disclosure, that's, not the most terrible thing we've ever heard of. Not that any kind of sexual abuse is okay and you can't really quantify, but the child's response, maybe they're just so traumatized and they're just really having a lot of symptoms. And then another kid comes in and they just disclose egregious abuse that's gone over years, and they're not displaying any of the trauma symptoms. They may later, and that's can certainly come, but it's not like an injury, right? Where there's like a superficial scratch versus a deep stab wound. It's just, we can't quantify it with objectively. We have to ask what the child's subjective experience is. We have lots of ways, and we'll talk about how to do that, but it's just, I think, important to know that the size of the trauma that we perceive may not match their response in our minds. And so understanding their perspective and where they're coming from is really important. And the kind of antidote or preventive mechanism for trauma is resilience. So resilience is the dynamic process of adaptation to or despite significant adversity by using protective factors and learned skills to manage stressful circumstances. So I think, we use the word resilience a lot, but kind of understanding what that is and how to really build it in our kids is important. So resilience allows a person to experience tolerable stress more than toxic stress. We're all going to face adversity. So understanding what we can do to help build up our strength and build resilience is really critical. So resilient children have strong executive functions, self-control of attention and impulses, and a strong personal identity. And resilience depends really primarily on the capacity for a young child to form at least one stable, caring, or supportive relationship. And that's really the foundation, is just having one. I mean, obviously more strong, caring caregivers or strong, stable caregivers would be better. But as long as a child has one stable caregiver, that can really, really make the difference in the child's ability to be resilient. And unfortunately, we know lots of our kids don't even have that. So terrible. All right. So what does childhood trauma look like in our country? Unfortunately, it's incredibly prevalent. So 34 million American children, almost half, have experienced at least one potentially traumatic early childhood experience. And we'll talk about what those can look like. Again, trauma comes in many forms. More than 1 in 7 adults report exposure during childhood to 4 or more adverse childhood experience. So those are the ACEs, and I'm sure you're familiar with ACE studies. So 4 or more, that's so many ACEs. And we know that the ACE exposure is dose dependent, right? So the more ACEs you have, the worse outcomes you have as an adult. And to see so many adults endorse that, we just know that there's probably even more, honestly, because it's underreported and underrecognized. And those ACEs include abuse, neglect, or other household adversity. We know certain populations are at higher risk for trauma exposure. Children who are identified as LGBTQ, which are current state, and by state I mean not a literal state of Texas, who is trying to quantify LGBTQ care as abuse. It's not, as we all know. But you can imagine that those children in Texas that are being told that their identity is abusive and the people that care for them and support them in their identity are abusers, it's just, I mean, that in and of itself is traumatic. So that is certainly an at-risk population. Children with developmental or behavioral problems also are at risk, and their behavioral problems may be due to trauma they've already experienced. So it's this like cyclical spiral that these kids can be on. Kids in foster or kinship care, of course, are at higher risk because they've had a disruptive relationship with their parents. Children who are incarcerated, and of course, children of incarcerated parents are at risk, and that's something that the hospital is currently working on, is identifying children of incarcerated parents more readily. And then immigrant children. Poverty is most commonly reported childhood adversity. And racism is another really common risk factor that magnifies the risk inherent to other special populations. So certainly there's intersectional trauma between race and poverty or LGBTQ or any of these other risk factors. And racism, of course, there's a broad range from obvious hate crimes, police profiling, bullying, and microaggressions that kids may face really on a daily basis. So it's just kind of constantly being exposed to these traumas that really cause an additive effect on these children. And then historical trauma is collective, transgenerational, emotional, and psychological injury of specific ethnic, racial, or cultural groups and their descendants. And I think this is an interesting one to think about, especially as we're like actively watching historical trauma be generated in the Ukraine right now. This term was originally applied to children of the Holocaust, and now it's used more broadly with American Indian and Alaskan Native children, as well as African American people, Mexican American, Japanese American, and really all different groups of people who have experienced mass trauma. And investigators that have looked at this link this historical kind of soul wounding to current health and behavioral disorders, including substance use disorder, domestic violence, and suicide, particularly in Indigenous communities. And I think that's something that you kind of hear about, but thinking about the child in front of you, can experience this or is living with parents who are experiencing this, which we're going to talk about what parent and caregiver trauma and how that can affect trauma-informed care as well. So here's just kind of a list of different traumas that can be outside the home: community violence, natural disasters. You can imagine, obviously living in a community with gunshot wounds, since we've seen gunshot wounds tripled in 2000. The patients that we saw at Nationwide Children's Hospital, the number tripled, gunshot wound victims between 2020 and 2021. So we know that kids are just living in more violent neighborhoods. Natural disasters, especially with climate change, we're going to see more kids who lose their homes because of flooding or fire or hurricanes. So understanding the impact of those. Unintentional injury, certainly a significant accidental injury is traumatic physically and mentally. Medical procedures or treatments, so kids that are end up needing medical intervention long-term for cancer or some other significant diagnosis. Terrorism, and then again, really in current events right now, immigrant and refugee trauma, including detention, discrimination, racism, not to mention just being completely displaced from your country. So we know we're going to see a lot of sequela in those kids. And then trauma can occur within the home. So partner violence between parents, that any kind of violence in the home a child is exposed to, it can result in these ACEs and adverse outcomes in adulthood. Parental substance abuse and mental illness, divorce, caregiver death, which we know so many kids have lost caregivers from COVID. So that's something, again, that we're going to see a different type of trauma from the pandemic. Separation from a caregiver, like we talked about earlier, parental incarceration, and then of course, blatant neglect and maltreatment of children. is traumatic. All right, so childhood trauma. So we've talked about a myriad of ways that children can be traumatized. So what can we do? As pediatricians, we really have the opportunity to identify and respond to early childhood trauma. But when we look at the data about, are we doing that? Pediatricians report deficits in knowledge, and time, of course, is something that's very, very precious to us. And we want to make sure we're using our time during these well child visits very effectively, and being asked to do a lot of different things. So making sure we can incorporate the trauma-informed care easily and seamlessly, and it's not adding a significant burden to the well child check. And then resources. So again, we don't just want to hand people phone numbers. I think, within Nationwide Children's, we're very spoiled by the presence of lots and lots of helpful social workers, but certainly at other private offices that resource may be more scarce. So understanding what resources you can leverage, and having a plan for if you do identify some of these issues that can contribute to trauma with families, like what you can do. And we can talk about some of those resources. We have lots of them here at the center. But trauma really needs to be considered as part of the differential diagnosis when we're seeing kids and adolescents for kind of every symptom they may have. Obviously, behavioral health kids act out if they're, dysregulated because they've been chronically exposed to violence in the home. Developmental, and of course, physical health, if they're being injured, we need to intervene there. So the definition of trauma-informed care in the healthcare realm is medical care in which all parties involved assess, recognize, and respond to the effects of traumatic stress on children, caregivers, and healthcare providers. So I think it's important that this definition encompasses not just the children, but their caregivers and us as healthcare providers, because one of the things that we have to be mindful of is that constant exposure and evaluation of children and their families for trauma can in fact traumatize us. And that's something we want to be mindful of. So the second bullet talks about that. So attention to secondary traumatic stress, the emotional strain that results when an individual, either the parent or the healthcare provider, hears about or witnesses traumatic experiences, past or present, of children. So that certainly is something that, within the hospital, we have the You Matter team that responds when there's, secondary victimization. But even outside, it's really important to think about what we're hearing on a daily basis. I mean, here at the CAC, our interviewers interview children with disclosures of sexual abuse every day. And that is not something that you can do every day and not really be mindful of the impact it's taking on their mental health. So that's something we spend a lot of time thinking about and try and make sure, again, we're using the resources that we have to protect ourselves. So trauma-informed care includes prevention, identification, and assessment of trauma and recovery as a focus of all of these services. So how do we do this? Every pediatric encounter is really an opportunity to promote family resilience and relational health. So early relational health is really establishing that foundation for resilience. So helping families and caregivers recognize if there are barriers to generating that nurturing relationship between kids and caregivers. So making sure that in the first 3 years of life, kids have strong support of their physiological, emotional, and moral development. I think, that's, and we'll talk about the screens that we can use even early on, but that's an opportunity if we notice early that a caregiver, just for whatever reason, isn't able to do, to generate this safe and supportive environment, that there's resources like Help Me Grow. There's nurse family partnership and other home visitation services that can be useful to really help support the parent, so that we can kind of build that resilience in this child early on and try and prevent any of these adverse childhood experiences versus having to react to them. So this is really primary prevention. So more generally, relational health is applicable to older kids as well. And really what we're trying to generate is that safe, secure, nurturing relationship. And this is an acronym I did not know until I was looking at these papers, but the SSNR is the safe, secure, nurturing relationship that helps both the caregiver and the child to thrive and build that resilience. So not only do we build resilience, it really buffers stress in these kids, so that when children do experience stress, they have a mechanism to do that. And trauma-informed practices support that relational health and family resilience as protective factors when they encounter trauma. You've probably seen this figure before. Stress exists, and there's lots of kinds of stress that are good. It's, something like, I'm going to present via Zoom to a bunch of people is a little bit stressful, but it's positive and it's fleeting and I can tolerate it. And, I'm not having a traumatic response from it. But then as the stress burden becomes higher, it's something more catastrophic, like a car accident, or even something not physically stressful, but a death of a family member can obviously cause much more toxic stress. And it's toxic in that the neuroendocrine immune networks become activated in these dangerous circumstances, and then they deactivate when the danger subsides. But if we keep having this heightened stress response, you get prolonged activation of the neuroendocrine immune system, and you really lose that balance and the homeostasis if you don't have that the relationship to buffer the stress, and you don't have that resilience to help buffer the stress. So when kids experience the toxic stress and they have this activation of their stress system, they end up with lifelong impairments of physical, mental, and relational health. And we can talk more about those. So here is a diagram from that policy statement, and it just kind of outlines most of what I just said. So early childhood adversity, so it's stress that's experienced. We have stress, and whether the stress is adaptive, tolerable, or toxic depends on the relational health. So as relational health goes up, so as they are in the secure, the SSNR, the safe, secure, nurturing relationship, kids are more likely to have adaptive stress, or they're more likely to adapt to stress and not have a big response. So primary prevention is what we're using here, and that's promotion of relational health during those primary care. Kind of in the middle is tolerable stress. So kids may end up having some mild symptoms. So we can kind of engage secondary prevention there, which we'll talk about, but that's the first part of trauma-informed care, is just knowing it exists. So realizing the effect of traumatic stress, what that looks like, especially during early childhood, and the impact on lifelong health, recognizing the signs, and then responding with practice management policies or referrals, whatever you need to do to respond to mitigate the response to the stress and get rid of that stress, right? So we want to put kids in an environment where they're experiencing less stress. And then in the worst case scenario, we have toxic stress, and then you're over to tertiary prevention, which is really referral to evidence-based therapy. So that's when you're going to start reaching out and getting behavioral health involved, lots of counseling, and needing to do more long-term interventions. All right, so here's kind of a different diagram outlining potentially traumatic experiences. Trauma symptoms are none to some, which is a little bit interesting to me, that you would have some trauma symptoms with no known trauma. I guess there could be unknown trauma that we don't know that could still cause symptoms, but yes, none to some in terms of trauma symptoms. And this is where the primary prevention anticipatory guidance, really promoting that resilient relationship between the caregiver and the child. Single incident or minor trauma, so something that's kind of isolated, not ongoing, may have no symptoms, may have some mild symptoms. So again, secondary prevention, helping parents understand what to look for, and obviously removing the stress. Major event or accumulative trauma over time could result in mild to moderate symptoms. And then so you're going to do the first two things, as well as start considering referrals for community services and mental health. And then in major events, that's really where you're going to engage long-term intervention. And again, I think it's really important that while this kind of says single incident or minor trauma, what is a minor trauma to one child is not a minor trauma to every child. And I think that it's important to understand the symptoms that you're seeing and even if you're like, gosh, that seems like a really out of proportion response to whatever the trauma is, that trauma is what it is to that child. And we just have to respond to the symptoms and not try and, not tell the child they're blowing something out of proportion, because that's not going to be helpful to them. So trauma has happened, and now we're in that secondary prevention place. So what can we do? Knowledge about, so first thing is that we know that what trauma is and that we're recognizing it. And then we want to, again, support that relationship, screen for trauma history and symptoms, and we'll talk about some of the screenings. Recognize cultural context of trauma experience. We have a lot of immigrant families here that we see. And so understanding what they've been through and what is an expected response, and how caregivers may be modeling a trauma response for their kids is important. So we just had a family that we were consulted on from Africa and non-English speaking. So we're doing this all through the interpreter and trying to understand kind of, it was an accidental burn because this family basically is living in one room and the mom was trying to iron and the baby crawled into the iron. There's accidents that happen, but kind of understanding like, how does this family respond to trauma? And, obviously an African family is more obviously going to have cultural differences, but certainly people that look more like us or speak, the same language may still have a cultural context we need to be aware of. For example, we see a lot of Amish families. And so just really knowing where they're coming from will be helpful. We want to give anticipatory guidance for families. So if, we see kids in the emergency department and we know they've experienced a trauma, our social work team does an amazing job of helping families kind of know what to look for, know how to talk to a child if they start asking questions, or if a child starts acting out or a child starts shutting down, those kind of externalizing versus internalizing behaviors, giving families some guidance of what to look for. Again, avoiding re-traumatization is important. Knowing when and where to refer for counseling, and understanding that certainly parents and caregivers can also experience trauma. So the strategies for implementation, and again, these are as outlined by those clinical guidelines. So awareness, readiness, detection and assessment, management, and integration. So awareness, again, the most fundamental adaptational mechanism for any child is the safe, secure, nurturing relationship with a safe adult. It's often a parent, but it could be extended family, or we see lots of kids that are in foster care that are really in kinship care. And having practiced in foster care for over 10 years, it's fascinating to me what qualifies as kin within foster care, but it's really somebody who kind of knows the child and isn't a foster parent. So I've had kids in kinship care with their football coaches. I've had kids in kinship care with neighbors. I've had kids that were in kinship care with an aunt or great aunt or whatever, and then that person couldn't take care of them, so their friend took over, but that's still kinship care. So I think kind of understanding what kinship care means is helpful, and how long this caregiver has actually been the caregiver for the child is important, because some kids come in and they are calling. This happened this past Friday when I was in foster care. They're calling their caregiver mom or dad, and I was like, oh, how long has this child been this way? A week. And they're calling this parent mom or dad, which speaks to how poorly attached this child probably is to any other adult. But understanding that really there can be a parental relationship with someone who is not related to the child at all and may not actually know the child that well. So knowing where they're coming from. But as long as that adult can be safe, secure, and nurturing, the child can develop resilient skills. And I think that can happen at any age. I think we want it to happen in the first 3 years of life, but certainly I've seen kids come in with terrible behavioral issues and acting out and really just signs of significant trauma in their lives, who they get in a good foster home and they do amazingly well. So I think it's never too late for these kids to get in a place where they can be supported and thrive, which is obviously what we want. The caregivers protect children from harm, mediate the world for the child, kind of help kids understand what's going on and why, help the child develop adaptive skills to manage their stressful responses. I have an almost 4-year-old, so we work on managing stressful responses every day in my house. Sometimes it's stress about turning off the tablet, but it's things we have to learn. And we know that kids' physiology and psychology are affected by these protective relationships. So in the same way that these ACEs really hurt their physiology and psychology, these relationships really build them up and are protective. We know, again, all kids experience stress, but within the context of having a safe caregiver, that stress can be good. And this table kind of goes through the physiologic effects of trauma, and I know it's really small on the screen, but I don't necessarily think we need to get into methylation patterns, but this just kind of demonstrates that it's really profound and significant. It's a very deep effect at the cellular level that trauma is having on these children. So brain connectivity can be impacted through cortisol acting rapidly especially on these developing brains, and you end up with kind of this association with more severe clinical course in depressive disorder with kids that have been traumatized early on in life. So we know that it's really impacting that fundamental neurologic function very early on. Epigenetic changes, so again, methylation patterns aren't something I necessarily think about every day when I'm seeing kids, but understanding that we are changing the genetics and how the genetics are, how their genes are transcribed and transcribed, and that's going to lead to adult stress and reactivity behavior. And if we can help these kids generate resilience, then we can really avoid these pretty significant long-term lifelong symptoms. And then immune function is the last one. So there's an alteration of immune system in response to that constant threat. And they get an upregulation of the inflammatory symptom. And so you kind of get this cytokine-induced sickness behavior, which I'm sure we've all had the experience of seeing kids, especially in that kind of early teen and certainly adolescent range, where everything hurts and everything's sick, and they have headaches and they, don't want to eat, or they're overeating, and they're moody and they're irritable. And some of that is normal teenage behavior, but a lot of that I think is just this just general inflammatory response from constant stress in their lives. All right, so here's another diagram from the stress responses. Again, we don't need to go through this super closely, but there's that kind of, if there's an acute stressful situation, there's freezing versus fight or flight. And then the affiliate response is kind of gather social support and tend to befriend. So this is what we want to try and build, is that in a stress response with support from the safe, secure, nurturing relationship, the stress goes down, versus no support in a hostile environment. You get a negative perception of others. You start acting out and behaving badly, which is going to cause more stress from the people around you. You have less adaptive responses, more antisocial behaviors that leads to those physiologic changes. So increased perceptions of stress, increased cortisol, and now you're just in this terrible feedback loop of the symptoms getting worse and the trauma getting worse. That leads to those negative outcomes that we see with lots of ACEs. All right, just a little bit more terminology from the paper. Again, this is a lot of words, and I'm certainly not going to read all of them. Some of them we're familiar with: ACEs, adverse childhood experiences, complex trauma, we've already talked about. PTSD is something I think we're generally pretty familiar with, but I did want to touch on a few. So there's developmental trauma disorder, which is a proposed diagnosis that is based on evidence that children exposed to complex trauma are at risk for these severe pervasive disruptions in their development, kind of everywhere. So emotional health, physical health, attention, cognition, learning, behavior, interpersonal relationships, and sense of self. And I absolutely see this in our teenagers that have been in the system for years. And even kids not in foster care can experience this, but it's just, I mean, they just really stop functioning on any significant level. And I think, when you look at their history and see that, they've been in foster care since they were 6 months old, and they were substance exposed at birth, and They have had behavioral issues. They've been diagnosed with ADHD and on all different meds. You can just see like they're going from home to home and disrupting, and they're not even having visits with family anymore. And it's just a wonder. I mean, it's no wonder they're just a mess, and they're not really successfully developing anywhere because they're basically trying to survive. So they end up with problems in affect dysregulation, negative self-concept, difficulty with relationships that occur as a result of trauma-related developmental impairments. You can imagine that these people become adults that then have children that they have no capacity to raise. And it's because they never learned how to be a parent because they were never parented. So you end up with these generational cycles of really non-functional people trying to parent, and kids being in the system. And I could give hours of presentation about our system being broken, but what we need to do is try and stop this at the get-go and really help these kids be in secure relationships so that they can avoid all of this in the first place. One of the other types of stress that's in this article that I'll just mention briefly is pediatric medical traumatic stress. So this is distress that kids and family members experience when there's a hospitalization for perceived life-threatening diagnosis. So, a child who's diagnosed with, a form of cancer and is here for a long time, or even a child that experiences, significant injury from a car accident. That is going to be very traumatic for the child and the parents. And again, this is something where I think our social workers do a really great job of working with families to help mitigate some of this stress, but it's certainly something to be mindful of. Social determinants of health, I think we're all very familiar with what those are. And the hospital within Nationwide Children's, we're really making identification of social determinants of health a priority by building a dashboard to Epic so that we can see where our patients are, where their families are, and evaluate that on a dynamic ongoing basis. So these are conditions of the greater ecology or environment. So where the child lives, where they live, learn, work, and play, that affect the neuroendocrine stress response, and in turn affect a wide range of health risks and outcomes. Again, these can be mitigated by a safe, secure, nurturing relationship and other protective factors, but also similarly can be exacerbated by ACEs and interfamilial and interpersonal traumas. So examples: poverty, food insecurity, homelessness, and lack of access to healthcare. And we know that all of those things go together. I mean, often if families are struggling with one of these or struggling with multiple, that's going to lead to a stressed out caregiver. That's going to lead to maltreatment in some form, be it neglect or physical abuse. And so these all go together in the same pool. And when we look at neighborhoods where we see kind of the worst outcomes of social determinants of health, like infant mortality, gunshot wounds, kids in foster care, I mean, the heat map of Columbus is the same for all of them. And it is, bright red over the Linden neighborhood, as you can imagine. Not just to call it Linden, there's other neighborhoods as well, but that's one where we definitely see a lot of families that we need to help, and we need to help them be able to kind of rise above some of these challenges so that they can have safe and healthy families. So, readiness. We know stuff's going on. We know families are experiencing it. What do we do? And I think it's all in how you frame the question, how you frame the conversations with families. So instead of using a what's wrong with you approach, and I'm not at all implying that anyone here walks into a room and says, what's wrong with you? But I think in medicine, that's kind of how we model. Like, we get a chief complaint. That is how we start a visit. And you have to put in a chief complaint in our electronic health record to document. So we're already at what's wrong with you, right? We're talking about a complaint. So reframe as what's happened to you. So your chief concern or chief, it doesn't have to be chief, but like what's going on in your life that's bringing you here today. And certainly if it's a well child assessment, which we do, what's strong with you? So what is this 3-year-old doing well? What are their strengths? Tell me something really exciting. What was the last thing that they did that was new and interesting? And I think, really framing for families that parenting is hard. Again, I'm almost 4-year-old. Parenting's hard. And there's lots of struggles, and certainly the environment contributes significantly to parenting being hard, and in different ways for different families. But taking a strength-based approach can kind of help families know, like, we're here to support you and build your family up versus we think something's wrong. So trauma-informed care acknowledges the biological effects of adversity without suggesting that adversity is the destiny. So what can we do to enhance these strengths, to build on these strengths, to understand, like, okay, what are the caregiver's strengths and what are their challenges? What are the child's strengths and challenges? And also, who supports them? So caregivers that have more support and more SSRNRs themselves are going to be better parents. And we know that. We know that understanding social support is very important. So instead of just trying to, like, fix a problem, trying to understand the patient and the sources of the problem, and not just the patient, right? Because in pediatrics, the whole family is kind of our patient. So understanding what the caregiver is going through and how we can help them avoid that issue. So pediatricians can support the caregiver-child relationship by understanding attachment. I think we do understand attachment and how important it is, and I think I've said that 10,000 times already in the last 40 minutes. So attachment, give and take between caregiver and the child, and building that trusting, safe, secure relationship that will help the child with healthy development and resilience. The attachment is malleable. Again, I don't think that all hope is lost because a 3-year-old didn't have secure attachment. We can definitely see kids develop these skills later on. And effective parenting occurs when the caregiver comforts in lots of ways. So touch, words, compassion, that can all help kind of shut down that stress response and restore emotional regulation. That needs to be predictable. Kids need to know that's there, and it's, as unconditional as it can be. And that's how they learn to modulate their stress response. And pediatricians, again, can discuss child and caregiver strengths and provide the caregiver empathy that helps them to reattune to the child. So I think talking about how parenting is hard, and the other thing is making sure parents understand reasonable expectations. So if a parent comes in and they say, it's really hard as my 4-month-old is really needy. Well, 4-month-olds by definition are needy humans. They can't do anything for themselves. So understanding, like, okay, this caregiver has no reasonable expectations for their 4-month-old. We need to help them reframe, and this 4-month-old can't do anything for themselves. They're going to be needy because they need you to do everything, and that's normal. And if that's not something that the caregiver can do, then what can we do to support that caregiver? So adding in those supports, and that's, those referrals are going to come into play. But really helping caregivers have reasonable expectations is very important for building this resilient relationship, and also avoiding child abuse, because that's when we see kids get hurt, is when parents have unreasonable expectations. So resilience, again, not static. Kids can learn over time. This is a mnemonic of the adaptational mechanisms of resilience. It's threads. It's a very long mnemonic. I'm not sure it's the most effective, at least for me, but you can see the T is thinking and learning brain, with opportunity for continued growth. H is hope. R is regulation. E is efficacy, or sense that one can impact their environment or outcome. So it's one's environment isn't their destiny. They can change it. A is attachment, D development, and then S is social context. And so I think approaching this as kind of an attitude versus here's the list of questions I have to add into my well child check to make sure I'm assessing for trauma and doing trauma-informed care. It's really just kind of, as the slide says, it's a vibe, like how we approach the encounter. So we can really incorporate this into our normal routine primary care that we're doing by building on identified strengths. So when we're doing that routine anticipatory guidance. And this is not just providers, right? This can be done with nursing and MAs, and the whole healthcare team can provide anticipatory guidance about development or safety that's done in a way to promote these relationships and positive experience, including highlighting achievements at home, at school, like what grade are you in, what's good about school, in neighborhoods, and really enhance that resilience across their environments. So when addressing adversities or concerns about development that have been identified, thinking about overcoming challenges as with a positive experience as the goal. So if you're talking even to a parent of a young child about a child learning how to fall asleep on their own, and you know, crying it out is stressful. I can't listen to my baby cry. Talking about sleep skills as building resilience by supporting self-regulation and self-efficacy. And we need to build this skill in the child so that they can learn how to regulate themselves, and make it more about child focused and building their skills versus focusing on how stressful it is for the parent. Not that it isn't stressful, because it is. So acknowledging that as well. Detection and assessment. So detection involves both surveillance and screening to identify families with a history of exposure to potentially traumatic experiences, as well as those who are exhibiting signs and symptoms of trauma, but may not, you know, say like, here's the trauma that happened, but they're exhibiting signs and symptoms that prompt us to ask more. So in the medical model, history taking, exam, differential diagnosis, and management. So that's all the things we do. And so all of these, all of our normal activities can help us turn up trauma and understand that that's what's contributing to the presentation. Surveillance for maladaptation can include those affected by exposure to direct suffering of a child. So again, if you know, the parent of a child who has had a significant injury or has a chronic medical illness, certainly could be traumatized as well. So watching out for that. Peri-trauma, so caring for a child as the trauma is unfolding. That's that pediatric medical traumatic stress that we talked about. And then triage. So is this an emergency situation, a non-emergency situation? Is this something like, this is an unsafe situation, we need to call children's services right now, versus this is something we need to follow up and monitor. And if a child is in an unsafe setting, of course, we need to report that immediately. And if anyone here ever has a question about it, my team is always on call 24/7 through PCTC, and we are happy to help navigate those situations, which certainly can be tricky. So with detection assessment, you want to start with open-ended questions, get more specific as needed, reflect back, make sure we're hearing everything correctly. Always be mindful of implicit bias. Implicit bias plays so much into these conversations because, we know it plays into everything that we do, but trying to understand that even if a family looks just like you and acts just like you, they may still be at risk for some pretty concerning issues. You know, certainly child abuse happens in every socioeconomic status, every race. There's not one that's protective. Also, just because a family doesn't act like you, and they may come from a area that is kind of red flag in terms of low socioeconomic status or a single parent or whatever that may be different, doesn't necessarily mean that something bad is happening in terms of trauma treatments. We're just trying to hear what they're saying and be very objective about our assessment. Social, developmental, and medical history, all opportunities to identify risk stressors and strengths. And you can assess the resilience factors, social connectedness, and parenting attitudes, just like who helps you take care of the child. It can be a pretty quick question. Review of systems can elucidate trauma symptoms. So obviously changes in sleep, appetite, toileting concerns, changes in school function, concerns for ADHD, number one behavioral issue that's gonna look like how trauma is gonna present. So they're gonna come in, families are gonna come and say, I need this child treated for ADHD. And when it turns out that, in fact, this kid is a victim of abuse or maltreatment, we have to tackle those issues. And because throwing Vyvanse at that isn't going to help treat the underlying trauma. Developmental delays, and then, like we talked about, changes in immune system. And here's another complicated mnemonic for the common symptoms of trauma exposure. So frets, which is really anxiety, regulation difficulties, attachment challenges, yawning and yelling, so sleep problems and aggression, educational developmental delays, and feeling hopeless, depressed, or dissociated. So one way to kind of do surveillance for this is anything scary or concerning happened to you or your child since the last visit. Pretty quick, straightforward, easily. Anything you're worried about in your environment that's changed. In the adolescents, doing the head screening that we should all be doing anyway. Asking about strengths of the child. What do they do well? Who are their supports? What's a recent victory or achievement that they've had? Again, playing up that kind of positive aspect of things that the child is doing well. And then super important, caregivers may and probably have their own trauma history or stressors that may impact their parenting. So we will see kids come in a lot to the CAC for evaluation of sexual abuse. And it may even be like an exam finding, like, oh, her vagina looked a little red. And because the mother was a victim of abuse, that is all that the mom can think about, is this exam finding has to be because the child was abused. It couldn't possibly be because she's a 3-year-old learning how to wipe herself. And so we do a lot of exploration here and around kind of why the parents think or have this concern when there isn't, some other disclosure of abuse. And so kind of understanding what lens these parents are seeing their kids through and their kids' problems, so that we can help them understand, why we aren't worried or what we can do to help with the problem. So trauma-informed care is compassionate. It assumes that all caregivers love their children and are doing the best they can. It also assumes that children are doing the best they can. And I think we've all worked with parents or caregivers that don't necessarily assume positive intent of their children. And so I think projecting that attitude and modeling that is really helpful for parents to see. So detection and assessment, lots of different screenings, ages and stages, the pediatric symptom checklist, PSC-17, strengths and difficulties, PHQ-9. There's lots of different choices. These are all validated questionnaires, and whatever you use, just as long as you're using some way to assess for typical development, and when we find that it's not typical, then looking for why. Exam findings that can be concerning: elevated blood pressure, abnormalities in development or growth, overweight and obesity, and of course signs of abuse or neglect. And we just really want to keep time on the differential for any developmental mental health or physical symptoms. And then we talked about how there's symptom overlap with ADHD especially. So management, you want to discuss the diagnosis with the child and caregiver. This could take a lot of education, and this may take multiple visits, and this can also take referrals. If there's someplace you can refer to that may be better equipped to have these conversations, that's fine. The conversation can provide insight, the caregiver insight to how their own trauma is impacting their parenting. And we want to give anticipatory guidance again. So thinking about signs and symptoms that the child may show and what the caregiver should watch for. Talking about reinforcing positive interactions between the parent and child to help build that resilience and help the child kind of deal and cope with the trauma that they've experienced. Promoting positive parenting. Of course, we want to avoid physical discipline. And then if there are findings or on the screening for social determinants of health, we want to refer for those appropriate resources to help the family get in an environment that is safer and more stable. Here's a picture of my center, which is certainly a place that you can refer kids to. We have adult service or families. So we have adult services, we have legal services, we have nurse family partnership, Help Me Grow. We have lots and lots of different services to help families in our area. So we want to try and reassure safety, encourage routine. Children thrive with routine, relaxation techniques, time in. So, kind of turning off all devices and spending quality time together as a family, celebrating small successes can really build that resilience and build that nurturing relationship. Referral for evidence-based therapy if needed, and then close follow-up and support. A trauma-informed clinic is a warm, welcoming space. Clear communications of expectations and procedures. We want to not surprise anybody with anything. Give choices when possible. I always ask kids, like, which ear do they want me to look in first? Sometimes just even having that choice is helpful. Making sure that all of the staff are aware of trauma-informed care and how trauma may be impacting patients that present, how to handle crises or when situations escalate, integrate care as much as possible, and then as needed, coordinating with other local agencies, schools, childcare, of course, and legal services. The last thing I just want to make sure, I know everyone's heard, but we want to make sure that we're taking care of ourselves. So staff and provider support, just really recognizing signs of burnout, and we do hard things. And so recognizing ways we can take care of ourselves so that we can keep doing hard things and take care of our families. This is the ProQual, which is a screening tool for burnout if you need to assess yourself or anyone else. That is the end of my slideshow. I can take any questions anyone has. I know we only have a few minutes left, sorry.
I don't see anything in the chat yet, but if anyone has any questions, now's your chance to send them in the chat.
And like I said, we're also always available if anyone has any questions and wants to reach out anytime, feel free. We want to support all of our partners in the community.
You're also free to take yourself off mute if you'd rather just ask your question then type it out. So this 22696 is the activity code. So you'll want to send that to the 844 number, and that will mark your attendance for today.
Kelly wrote in the chat, do we have quick tips or suggestions on how to train staff in the primary care setting? I'm actually relatively new at talking about implementation of trauma-informed care in the clinical setting, and I certainly would be interested in learning more about that. So let me follow up with you on that. It's an excellent question. I think it's something, I don't even think it doesn't need to be as exhaustive as this. I think it's something that is important to think about. So I will, Kelly, you're here on campus, right? Yes, okay, pretty sure. I can look into that.
All right, well, thank you all for joining us this afternoon.
Oh, all right, Kelly, I will reach out to you at Keys Associates. Okay.
Thank you for joining us this afternoon. And our next training, if you want to save the date, is May 11th. And one of our psychologists, Dr. Emily Newton, will be coming to present on how to make your practice more autism spectrum disorder friendly. So that be on the lookout for that flyer and calendar invite here in the next few weeks.
All right, Avis, I will write down everyone's email addresses.